Buenas tardes. Buenas tardes. Para la siguiente actividad que tenemos aquí en el Congreso, va a ser en idioma inglés. Si alguno de ustedes requiere ir por el aparatito para traducción, vamos a dar unos minutos para que puedan ir por su traductor para empezar.
Sí. Hacemos un anuncio. Si alguien extravió un celular iPhone, se reportan aquí enfrente de la sesión.
And this is for to change the slides over the presentation? Yeah. Which button should I not touch? Because he does it all the time. Okay. I think that one is the one that is... Yeah. That's it. It's not good. Okay. Don't worry.
Yeah, I'll leave it here.
Okay. Vamos a pedir por favor a todos los asistentes que en cuanto sea posible podamos tomar nuestro asiento para poder empezar. Muy bien. Bueno. Good afternoon. Welcome to this roundtable that we will start at the conference of the Anthem. My name is Edgar Herrera, the director of the Society for Simulation in Healthcare, and I'm very thankful with the Anthem for this opportunity to be here alongside two distinguished global experts in education and simulation, Professor David Cook and Professor Peter Jong. Today, we will have the opportunity to listen about how important is simulation in order to enhance healthcare education. Medical schools and faculties in Mexico and around the world have adopted the simulation methodology, transitioning from being a curiosity or exhibition activity into integrating them in their medical curricula. We know that this session will be of great interest to all of you, and we invite all the public in order to participate with the speakers at the end of their opening presentation. Excuse me. So I would like to introduce our guest. First, I want to introduce Dr. Peter Jong. Dr. Peter Jong is a senior advisor and researcher in the field of technology and enhanced learning at Leiden University Medical Center in the Netherlands. He leads a team of the development, implementation, and support of online learning materials, and he provides strategic advice in the field of technology and enhanced learning. His research interest is in the field of online and blended learning in medical education and the use of extended reality applications. Our second speaker is Dr. Cook. Dr. David Cook is professor of the Medicine and Medical Education in the Mayo Clinic College of Medicine and Science, a practicing physician specializing in the diagnosis and treatment of complex medical problems, a deputy editor of the journal Medical Education, and a member of the editorial board of the journal Simulation in Healthcare. Dr. Cook's research interests include the theory and design of online learning and other educational technologies, the quality of medical education, research methods, and reporting clinical reasoning and assessment of clinical performance. He has published over 250 journal articles and book chapters on medical education topics. His H index is 92, meaning he has published 92 papers, each cited 92 times. Some honors included the Mayo Clinic Distinguished Educator Award, Mayo's highest award in education in 2021, and Society for Simulation in Healthcare Researcher of the Year Award. He teaches also Sunday school in his local congregation of Church of Jesus Christ of Latter-day Saints. He and his wife, Jennifer, are the parents of 5 incredible, wonderful children. Please give a welcome to our 2 speakers. Vamos a empezar, para la introducción en inglés, vamos a empezar con una breve presentación por parte primero del Dr. Peter Jong y después otra breve presentación por parte del Dr. Cook para después abrir la mesa a preguntas por parte de todos ustedes hacia nuestros ponentes. So, Dr. Peter, the microphone is for you.
Okay, thank you very much for the introduction, and thank you very much for the invitation to be here today. I've been at MFAM meetings before, and it's always good to be back in your community. I'm going to show you a few things with the use of technology in the field of simulation. Those are just examples, things that I can show you to set the stage for today for the discussion. I was already introduced. I'm from the Netherlands, 8 hours in time away from here, where I work at the Leiden University Medical Center. And I've also been active, as you can see, within IMC, the International Association of Medical Science Educators, where I did a lot of work in scholarly work and publications, and I was honored to be their president for 2 years. Simulation. I think you know all about simulation because this conference is about simulation, but simulation, a simulation environment for healthcare education is a structured and a realistic learning setting that replicates clinical situations using tools, and those tools can be anything. We think about mannequins, actor patients, virtual reality, computers, anyway, to allow the learners to practice things, to practice their skills, clinical skills, technical skills, communication skills, and of course in a very safe environment. If you do something wrong in the simulation, nobody's going to die. Sometimes I think we often think that simulation is something new, maybe from the last 20, 30 years, and that's not true. As you can see on this timeline, I found this in an article from a few years ago. Simulations, or trying to find something that represents something in medicine, is already very, very old. 2,000 years before Christ, we already have examples. And it goes into figures or wax models. They all try to make some kind of things to simulate things, to make them, to learn about things or to teach about things. And only in the last 20, 30 years we are handling with simulations as we know, as the simulations that we are talking about. And an example of that very, very, very old time is this, which is a model of the liver. So this simulating things is already something from very, very long time ago. We use technologies, and you can use very different technologies. One of the simple ones is just to use a computer. Think about e-learning, think about short videos to simulate things, to show things. A laboratory simulation, as you can see on this picture, is a clear example where students can practice without exploding the laboratory immediately. They can practice their stuff before they go into the laboratory. But there are more nicer, sophisticated stuff than only computer models. We often talk about high-fidelity simulation, and high-fidelity simulation can use actors in real environments, but it can also use mannequins, and then, sophisticated mannequins or virtual reality to create a high level of interactivity for the student, for the learner. It is very authentic, it is safe, and you can even use it interprofessionally with others together. This is an example. These are pictures from my school where we are using an actor to create a simulation in the field of pharmacology. Something's wrong with this actor and he got very sick and he used too much medication. And the group, as you can see, there are students around it. As a group activity, they are really going through this simulation and trying to find out what's the problem with this patient and how to solve it. You can see it looks like a quite authentic environment. It's really a patient in a hospital bed. There are doctors around it. It's safe. We have a lot of discussion with the students, and in this case we are using students from two different programs. Those are medical students and pharmacy students working together. And they have a different view on things, and that makes it so much fun to run this simulation. But you probably also think about very sophisticated mannequins. Now, those started a little bit in the 1960s. You probably know the Harvey simulator from Dr. Gordon. That's a very famous one. And those mannequins were not only mannequins, but they were really replicating the human physiology. They responded to something if you changed something. You could touch them, you could do all kinds of things with it. And those equipment, that kind of equipment is of course very big and very expensive. So you not take this home as a student. You can only do this in sim centers where it's an environment to train people. Sim centers we find all over the world. A lot of schools have them. This is an example of here in Mexico City, Universidad Panamericana. I had the honor to visit them last year, and this is a few pictures of their simulation center where they train their students. As you can see on adult mannequins, but also on children and little babies. And another example is from another country, from Canada, from Montreal. This is the sim center at McGill University. Same thing, a very authentic environment, a real hospital room with a patient, and also a control room, as you can see, where the technician is controlling the simulation to make it more complicated or more easy for the students to handle. We are using nowadays a lot of extended reality technologies. And what is extended reality? It includes three types of technology: virtual reality, augmented reality, and mixed reality. And what it does is that it adds something to the real world. Virtual reality, people are wearing a headset and they cannot see anything else, so you have to be careful. If you have a headset like that, you cannot walk the stairs because you will fall. You cannot see anything, but you see a virtual world in front of you, a really digital environment. You can look around. The headset knows when you are turning. You can see what's happening behind you. You can also interact. You can touch things that you see here to get more explanation, for example. These are a few pictures of a simulation that we offer our students to get used to the hospital. Before we send them into the hospital, they already can explore a little bit what's happening over there. It's in fact very simple, but it's helpful for them to prepare. This is another example of how we use technology like this. This is also virtual reality with a closed headset, and it's only a 360-degree video, but it's a video that we created from an operation procedure. This is a kidney transplantation. The whole video takes 2 hours. It's a real transplantation. There's a real patient there. And we do this because our group of students is 300 students every year. We cannot put all those students in this room. That's not possible, not allowed. So by using this simulation, we can give everybody a good opportunity to know more about what's happening in an operating room. And this is for the second and third year students. They can watch who is there, what kind of professionals are working during an operation, what are they talking about, what is their role. So they can learn a lot of things, and otherwise we could never have put all those students in that room. Augmented reality is a little bit different. That's using a device, like you can see here, a tablet or a phone. If it has a camera, and then you put the camera on something, and then the computer recognizes that something and says, hey, I know more about this topic. For example, you see here there are number 1 and 2 and 3, so the computer now all of a sudden has extra information on the things that you see. That's called augmented reality. The Pokemon Go games were kind of like that. And it is used in education, but not so much as the virtual reality. And the next one as the mixed reality. Mixed reality is also wearing a headset, as you can see, but this is different because you can still look through it. You can still see each other. You can walk the stairs with this one, but you can also see something in the room that other people cannot see, and that is the hologram that you can see in this picture. That leg in the air, that leg is not there, of course, that's a hologram, but you can only see that with the headset on. So that really makes a combination between the real world and a virtual world. And with this technology, we can teach things that we cannot show or teach without technology. This would not be possible because we don't have holograms in the air. So this is quite interesting to simulate some things. We use that technology in our clerkships for internal medicine. You can see here that students are practicing on each other or on somebody to listen to hard sounds and to long sounds. And with the technology, with the glasses, they can even see what is supposed to be inside the body and why you can hear the long sounds better from this position than from that position. It adds an extra layer to it, which can be very helpful to understand better what you're doing. This is one step back, a virtual reality used for communication. The patient or the one that is using the simulation really experiences what happens if somebody comes to you and bring you to the operation room and what the nurses are doing and how communication should be done. And this is an example of mixed reality again, to train people in ultrasounds. It's a difficult skill. But you can train this as much as you want. But also by the glasses, you can see that on the right, you better understand what is in the body and why it works better if I do it like this and why it doesn't work if I do it like that. So that brings me to the end. These were a few examples of things where we can think about if we're using technology in simulation. So where are we going? I think that mixed reality applications, they will be even more developed as they are now. There are some schools already working with smell. So even if you're in the virtual reality, and if you do something, then all of a sudden you can smell what's happening. So that's entering a fourth dimension to the whole thing. They will become more and more realistic with the use of AI. AI can bring us conversations, students can ask questions, and they will get better and better good answers. And in the past, years ago, we only had responses that were pre-programmed. And if you ask a stupid question, then the computer didn't know what to answer, but AI can help us to give reasonable good answers. So it becomes even more realistic to train. I expect that things will get more mixed, using a combination of virtual reality and actors, still mannequins, but using things more and more together, while we are using them now more separate. They will be used more and more, I think, in multidisciplinary training sessions. We already do that. You can use those simulations with multiple professions in the room, or the example that I showed with multiple students in the room from different programs. And last, I would not be surprised that we will, as faculty, as teachers or as doctors, we will probably run into a moment where they will assess us and they will evaluate how we are doing, just in a training session, that maybe not in real life, but you can have an assessment on how you're doing. This concludes my quick overview. I hope it's a nice start and an overview of what we can expect with technology and simulations. Thank you very much. And I go to Dave.
Thank you, Peter, for that excellent introduction. So Peter has talked about the various options for simulation. It was a very comprehensive, excellent overview. Now, I want to shift our attention and think a little more about the future and the evidence that we have and the evidence that we need to collect. In particular, I want to emphasize, what do we know about what makes simulation work? What do we need to know? And what can we do now to advance our knowledge? So, what do we currently know about the evidence? Well, 15 years ago, I did a systematic review of simulation-based education and found 609 articles that compared simulation versus no intervention, 92 articles comparing simulation versus simulation, two different modalities, and 289 articles comparing different forms of simulation to identify what works best. This is a summary of the publications over time as of 2011. You can see that it was increasing rapidly, and it's only accelerated since that time. If we got this graph and continued to the present day, we would see a continued exponential growth of publications. So it's a very hot topic. Lots is being published here. As of, again, that 15 years ago, this is the topics that were being published on, particularly minimally invasive surgery, code training, and endoscopic procedures. I think Peter pointed out that in the future, with new modalities, with standardized patients, with mixed reality, we may see this change, but for the most part, this continues to be the case. Most simulation research is published in procedural skills, especially surgery and anesthesia. So what do we know about whether simulation works? Well, again, as of 15 years ago, we clearly could see that simulation in comparison with nothing was way, way better. An effect size of approximately 0.8, some effect sizes as high as 1.2, suggesting that simulation works, right? It shows a large effect, a large benefit compared to no intervention. Well, what about, actually, this is a slide, what's called a cumulative meta-analysis that shows the studies one by one coming in year by year to tell us when did we have a good understanding of whether simulation worked or not. The first study was published in 1973. It did find a statistically significant benefit from simulation compared with nothing. The second study was published in 1980, and at this point, it was clearly beneficial, and we never went back. Starting in 1980, we already knew that simulation worked in comparison with no intervention. However, just to be safe, we did another 607 studies to make sure that we were not incorrect in our assumption. Now, I say that with as a bit of a joke to say, we really did not need those 607 studies. They were completely unnecessary. This is as of 15 years ago, and if we continue to do our search right now, unfortunately, we have published another 500 studies, at least, since this time. We keep publishing studies that tell us the same answer to the same question. Simulation works in comparison with no intervention. That includes single group pre-test, post-test studies of your new curriculum trainer, your new curriculum. This includes even randomized controlled trials comparing simulation versus no simulation. We simply don't need those studies. We knew the answer in 1980. 46 years later, the answer has not changed. So don't do this. It even includes patient outcomes. As of, again, 15 years ago, we knew the answer that simulation improves patient outcomes. We don't need studies examining this question. Well, what about comparison with other education? In this case, other simulation. Other non-simulation. So this is simulation versus not simulation. And what we see here is that simulation does help in procedural tasks. It doesn't make much difference in knowledge, but it does help with procedural tasks. In other words, we can clearly see that when hands-on practice works, simulation is better than a lecture or a small group session when it comes to doing something procedural. That makes obvious sense. That doesn't necessarily take a randomized controlled trial to tell me that. But the randomized controlled trials do confirm that it does work. Well, what about assessment? We looked at this separately. Here we found 417 articles as of 15 years ago. And of these, we took the better half, the top 50%, and studied those in depth. And I'm just going to show you one very short slide to show that what we see is that these studies, even the better one, these studies were not done very well, is the bottom line message of this study, of this slide. It shows that validity evidence was poorly reported. Very few studies reported comprehensively the validity evidence to support the assessment tool. So 417 studies, but the overall quality of these studies is very poor. So what do we already know? Simulation works. So now what? Well, what do we need to know? And I would suggest that what we need to know is how to make simulation better. We know that it works, but how do we make it work well? And we specifically want to understand when to use specific simulators or specific instructional approaches. We want to take into account the cost of simulation. Some simulation is extremely expensive, some is extremely cheap. Are the cheap ones just as good as the more expensive ones? At the Mayo Clinic, we actually have a lot of, you'd think that we, as a worldwide global brand name, would do a lot with expensive simulation, but we actually don't. What we specialize in for our surgical specialists is really, really inexpensive simulation that costs like $1 US dollar, or 200 pesos. Would be a good simulation model. Very, very cheap. This doesn't have to be a $50,000 virtual reality simulator. Inexpensive simulation works, and that's particularly important for lower middle income countries. We also need to align the simulation and the instructional approach with the objectives of the course, the skills that are desired, the clinical context, and so forth. And finally, with assessment, we need to collect validity evidence. As I said, the validity evidence thus far is very weak. We want to do better with that. Well, that was 15 years ago. What about today? Well, in 2023, the Society for Simulation in Healthcare conducted a research summit and commissioned 12 systematic reviews. These were commissioned reviews. And we provide here a summary statement of what we learned from those systematic reviews. This was published in Simulation in Healthcare in 2024. Here is a summary of the systematic reviews that have been published so far. In situ simulation, healthcare debriefing methods, just-in-time learning, spaced learning, meaning you do it, there's a time gap between training activities. Mastery learning, meaning that you continue training until you get to a certain competency threshold. Training for teamwork skills, fidelity and simulator realism, extended reality interventions, distance simulation, formative assessment, and faculty development. And from all of this, we distilled several practical take-home recommendations. None of those recommendations were considered strong. 0 strong recommendations. In other words, the evidence base is still relatively weak. We found 3 moderate recommendations, namely in situ simulation helps. In situ simulation means simulation done in a clinical setting. So instead of making our learners come to the simulation center, Peter showed some beautiful pictures of simulation centers around the world. Instead of having them come to the center, we actually take the simulation to them. It's portable. We go to the hospital, we go to the ambulatory care center, we go to the urgencia, and we actually do the simulation on site. That has several advantages. Number 1, we don't have to have a special dedicated center. Number 2, it means that workers can continue to work and take care of patients, then take a short break for 20 minutes to do a simulation, and then get right back to work, instead of having to take time off, travel to the center, come back. So in situ simulation works well. Number 2, high frequency works better than just a one-time practice opportunity. That makes sense. Multiple repeated learning opportunities are obviously going to be better than a single one-shot activity. And then competency-based training helps. Training to a mastery threshold is effective. These are the 3 moderate recommendations. We had several weak or uncertain recommendations. Just-in-time learning might help. Spaced and massed practice seem similar, but there were only a couple of studies, so we need more research here. Lower fidelity may actually be better than high fidelity. That's an interesting twist, probably because learners can practice more. If it's high fidelity, it's expensive and limited. It's a limited resource. If it's low fidelity, they can take it home and practice on it from their house. Both distance and in-person help. Teacher training helps. Debriefing helps. And both XR, extended reality, and traditional simulation are good. That's not a lot to have learned from 50 years of simulation research. We know that simulation works, and now what? We're stuck in the same question. So how do we make it better? Well, back in 2005, Barry Eisenberg proposed 10 different things that seemed to him logically would make simulation better. These were not grounded in evidence, these were grounded in logic. Clinical variation, distributed or spaced practice, feedback, team training, individualized, customized, tailored training, competency-based or mastery-based learning, using multiple learning strategies, having a range of difficulty, deliberate or repeated practice, integrating it into the curriculum, and having an acceptable level of fidelity. Well, what did we learn from this? In our review 15 years ago, we examined these and found that most of them worked, but look how few studies there were. For some of these, there were only 3 studies, 7 studies. A couple had like 70 studies, but that was just for multiple strategies. So teaching people in lots of different ways works better than teaching them in just a single way. That's nice, but it's not very insightful, not very helpful. It doesn't really tell me what to do. So we confirmed 15 years ago that Barry Eisenberg's proposed features work. What did we learned since then? Here's the evidence. Here are the recommendations from the 2024 guidelines. You can see that a couple are moderate, most are weak. Actually, most are still empty, and a couple of them are weak. I would suggest we still don't know a lot from an evidence-based standpoint about what makes simulation better. Now, we can still do these things, right? Based on logic, we can still proceed to do this, but the evidence base is weak. And so if you're going to do research, we want to frame our research around these gaps. We want to focus on the gaps, right? If you're going to do research. So then let's think about when we would want to use a specific simulator or approach. Here we see in situ simulation works, just-in-time learning might help, distance and in-person both help, and XR versus traditional both work. That's all we know. That's not very much. When we think about when, I want to focus on value defined as benefit versus cost. We always think about the benefit. We never think about the cost. We know lots about that simulation works. We don't know how much it costs to actually realize those benefits. And especially for lower middle income countries, that's important. But in the United States, it's important too. People don't have a lot of money to throw around at simulation. So we have to think about the true value, the cost effectiveness. We looked at this back 15 years ago and found that of the 967 studies, only 6% reported anything about cost, and only 15 reported the comparative cost, meaning that the other 44 studies said, this is how much my simulator costs. But that's all. They didn't make a comparison. So there's a lot still to be learned about the cost and value of simulation. I like to emphasize getting the right tool to the right learner at the right time. And for here, we can see that there's a link, a conceptual link between the learning objective and the specific simulation approach that we might want to follow. This is theoretical. There is some evidence to confirm that it works, but this is largely conceptual, came out of my mind and Mark Triola. We came up with this. It's yet to be confirmed. What about assessment validation? I will come back to this slide later on if we have time. For the moment, I'm just going to skip that, but just say that there's a lot to be written about simulation, and you can look up the articles later on if you want. So where do we go from here? What can you do? What can you do? And I would suggest you need to ask and answer important questions. Focus on when to use simulation, not if. We know that we need to use simulation. We don't need to ask that question anymore. We know that it works. We want to focus on when, and that includes the cost. And then once we've decided to do it, we want to learn how can we do it better. I and some co-authors recently published on 5 common pitfalls in education research generally. This is not simulation research. This is all education research. The article was published last, I think, September 2025. The 5 pitfalls are redundancy. Authors, researchers don't pay attention to previous work. They come up with an idea while they're driving into work and they go do a research study, but they don't bother to look if someone studied that 10 years ago or 20 years ago, and the answer is usually someone did. Second is context specificity. What works at the Mayo Clinic only works at the Mayo Clinic. What works at Merida only works at Merida. We need to expand beyond our local institution to a global focus. Number 3, confounding, which gets to the issue of cause-effect relationships. Can we establish a clear cause-effect relationship? And then second, dilution. Can we detect the signal? Can we detect the effect if it's present? Fourth, superficiality. Most of the time when we do research in education, we are collecting data that is convenient. Convenient data that's already been collected. We're not prospectively studying it. This is the data that are easy to collect. We need to focus our efforts on planning to collect the data that best answer the question. That's really important. And then finally, the idea of conceptual obscurity, the absence of theory. So when we think about this, the answer is to use theory. So when we think about asking important questions, rule number 1, don't start with a tool or data. Don't say, I want to do a survey. Don't say, I want to do a study on OSCEs. Don't say, I want to do something qualitative. Focus on your question. Second, don't make comparisons with nothing. We already know the answer. Things work, education works. Number 3, think about who cares outside of your institution. Think about how, why, or when. Think about assessment validation. And then finally, think about what's already been done and what's next. This is an article I published 20 years ago looking at how to ask important questions. We think about descriptive studies, justification studies, and clarification studies. Description are just that. You describe what was done. Justification studies compare the new way versus the old way. And clarification studies focus on how, why, or when an activity might work. And here is the focus. These clarification studies focus on the questions that really matter most. So what can you do from here? This is my final bottom line, and I thank you for your attention.
Thank you very much for your presentation. Vamos a abrir entonces ahora el micrófono a todos ustedes para que por favor, si tienen alguna pregunta que quieran hacer con cualquiera de los ponentes, por favor la puedan llevar a cabo. Por acá tenemos una mano alzada.
Muy buenos días. Armando Amaro, director del Centro de Simulación para Excelencia Clínica y Quirúrgica del Instituto Mexicano del Seguro Social. En el IMSS tenemos 3 centros de simulación hasta ahorita, uno en la Ciudad de México, uno en la Ciudad de Guadalajara y la tercera aquí en la Ciudad de Mérida. Una de las características que tienen los centros es que damos capacitación y formación a personal de pregrado, posgrado y al personal de base que trabaja y labora en el instituto, tanto de categorías médicas como de otras categorías como asistentes médicos, trabajo social, etc. Se dan obviamente cursos en donde se utilizan los simuladores y vamos desde la Simson 0 hasta la 4. Pero algo que nos ocupa es que hoy en día la sociedad nos está exigiendo una humanización de la atención médica y del personal de salud. Y el Instituto Mexicano del Seguro Social, ocupado sobre esta situación, damos cursos sobre competencias transversales de un tema humanístico, como puede ser intervención contra la violencia de género, empatía, inteligencia emocional, entre otros temas. Y hemos estado dando muchos de esos cursos a todo el personal, tanto en formación de pre y posgrado, como al personal de base. Mi pregunta es, ¿cuál consideran que sea el futuro de la simulación clínica en la capacitación y aprendizaje de estas competencias transversales para poder fortalecer una atención de calidad e integral a nuestros pacientes? Gracias.
Muchas gracias, doctor.
Thank you very much. I have a lot of noise on my headset. For me, I think the things that we talk about today, simulations, is just one of the teaching modalities that we have. And I think Dr. Cook already referred to it a little bit. It's one of the things that we have. You want to train people now in that area that you mentioned. Yeah, you can do that in a lot of ways. You can give a lecture, you can a lot of things do, but simulation has the good thing about simulation is that you can work in a group. You can try it over and over. Maybe you can video record it and watch it afterwards and say, okay, was this very empathic what you were doing? What do you think yourself? So it's just one of the modalities that we can use. So your question was a bit, is there a future for this kind of trainings? Yes, I think, why not? It is just one of the options. You can take so many other things to train people. And this is a powerful one. The keynote of this morning was also talking about communication and working in teams, and that not maybe if one is not so very competent, still the team can be very competent. Yeah, you can train that in simulation centers, in simulating settings. So yeah, I think that there would be a great future for that kind of thing.
Thank you very much, Doctor.
Hello, I'm Katy Coral from Universidad Autónoma de Yucatán, and I want to know your opinion about include real patients in simulation to train communication and this medical patient-centered attention. What do you think about this strategy of include real patients?
So I think it's absolutely very useful. And when we did our systematic review, we were puzzled on how would we count for patients who were included in a research study. did they count as real patients or did they count as simulation? And what we decided, because with a systematic review, you have to make decisions about what is included or not. We decided that if a patient was getting regular, routine clinical care, then any training done on that patient was not simulation, it was real clinical care. But if a patient was used in any way that was not required as part of their clinical activities, then that counted as a simulation. So for example, if I take students to the bedside of a patient in a hospital so that they can listen to that patient's lungs and learn about lung exam, that's a simulation. We do it all the time. And so in our systematic review, we would have counted that as a simulation activity. So to answer your question, there are actually a lot of studies done on that. We counted them in our systematic review, and absolutely it's a good idea, and absolutely we should do it. The only question you have is you need to make sure to get the patient's permission. But if you have the patient's consent to do that, then patients can be wonderful for simulation. Sometimes we pay them, and then we call them standardized patients if they are trained and paid. But whether or not you train and pay someone to do it, or whether you're just asking them to volunteer themselves for use, real patients are a wonderful way to simulate.
But on the same page, I think that you have to be very thoughtful and careful when you do it or not. Because, yeah, we do have, we use real patients as actors because they know so very well how they want to be treated and how it is to be a patient. But a simulation is also should be a safe environment to practice something. So if we are going to practice breaking bad news, maybe I'm not so very competent in it and I'm making a stupid mistakes. I can hurt a patient very much if I do it in the wrong way. So I think you have to be careful that you can only do it in those situations that are not harmful, because otherwise the space is not safe anymore for the students or for the doctors to train. Make sense?
I want to add one more thing, which is there is a very important ethical issue with using patients for simulation. We have to be transparent with the patient that they will be used for that purpose. A classic example, well known, well done, and I did this as a medical student because I was told to do it, but in retrospect it was probably ethically incorrect, which is the common practice of doing a gynecologic exam, a pelvic exam, on a woman who has been anesthetized for a procedure. It has been very common. I don't know if any of you have done this at your institution, but a woman who has been put unconscious for a surgery, sometimes they will have students come through and do a pelvic exam, and 3 or 4 students will do a pelvic exam on that woman while she's unconscious. And that's a great experience for the medical students, but it is a violation of that woman's autonomy and her privacy to do that unless you ask her permission. And so, again, the idea is that it's wonderful to use patients, but you have to ask their permission, you have to get their consent. There are some ethical issues that need to be addressed, but yeah.
Thank you.
Yeah.
Please. Thank you very much. So, adelante. Adelante.
Good afternoon. I'm a third-year medical student, and I have 2 important questions to ask you. But first, thank you so much for the conference. First, when we get used to simulation practices, we tend to mechanize the medical procedures. What do you suggest we add to the classes to prepare and improve ourselves for real scenarios where things go wrong, or we can follow an algorithm? And also, how important or is the student satisfaction with the learning of better academic skills?
How do you prepare students for the stimulation with technology? Is that what your question was?
No, the first one is, well, I happen to have a lot of exams with simulation, and we tend to mechanize a lot of the procedures. So what can we do, or how do the classes need to improve to prepare ourselves when something goes wrong?
So I actually have a thought, and Peter, then
Yeah,
you can
then
maybe.
I'll jump
So
in.
I think there are two ways that we can prepare students for the simulation. One is to help make sure that they are comfortable with the simulation modality and the simulation task. It's the structure of the simulation activity, not the task that we're trying to train, but the activity. Help them understand the goals. Help them understand how the room is laid out. Help them understand how the simulator works. Help them understand how the simulator works and how the simulator maybe doesn't work so well, so that they can focus on what's important and not get worried and frustrated with the simulator that isn't perfect, because no simulator is going to be perfect. It's always going to have some flaws and some shortcomings, so we can train them on the simulation activity. The other, though, is to make sure that they have the necessary training on what they're trying to learn. So we've done some research at the Mayo Clinic several years ago where we looked at whether you gave people a pre-instruction training activity before they did the simulation versus not, and found that pre-training really helps. And there's been other studies that confirm that. So a short online module, a one-page paper handout, a quick review before they do the simulation activity can go a long ways to making that activity successful, so that they go in prepared for the simulation. That way they're not frustrated trying to learn the basic essentials or the steps of the procedure. They've had it refreshed in their mind. What are the steps? Now they get to practice trying to do the steps. They know them in their mind. Now can they get their hands to do that? Or they use, they know what to do. They're supposed to, when they talk with the patient, now can they actually have a good conversation with a standardized patient? So again, help people train for the simulation activity, and then help prepare them to succeed in the task itself.
Yeah, and we see that with the more technology you're using, for example, the headsets, and we see that in our situation as well. You really need to let them play, to let them practice for a little bit, because you are spending so much brain power on how to do this, or you get a little bit dizzy, or those kind of things. You don't want that. So we notice in our practice that you really have to prepare students by giving them some time to get used to it. And then, but otherwise the training itself will not be very successful. We have that, yeah, we do have that experience.
I would just say that's particularly important for XR, headset, the
Especially.
VR headsets
Yeah.
and things like that.
And maybe something to mention is that we talk about simulations and students, but there are also teachers. And teachers should also be, maybe they should be trained in how to use simulators. And I think there are also teachers among us or in the world that don't like simulations so much. They think, all those technology, that's not for me. We did this years ago without technology, so I still want to do it without technology. So it's also important to look at teachers. They also have to be very well prepared on how to use these kind of simulating, and especially the technology. Otherwise it's not going to be fun for the students.
Thank you. I also have this second question. Is that have you found a relation between the satisfaction of the students with the outcome of the practice?
So, honestly, I don't care if students are satisfied. Why do I say that? I say that because learning is hard. Learning is challenging. Learning can be frustrating. But those very challenges are what make learning rewarding. When we talk about learner preferences or learner satisfaction, the most satisfied way I would be to learn is to go to Cancun and sit on the beach with a nice cold non-alcoholic drink in my hand, because I don't drink alcohol. Sit there on the beach and and put on a headset and learn all the things I needed to learn about medicine. That would make me very happy. But of course, we all know that that does not work. What works is to put in effort with learning, whether that's learning something cognitively, whether that's learning something with our hands.
And so we know that errors are one of the most important ways to learn. And we know that hard tasks are important for learning. And so those things make students unsatisfied. So yes, all things being equal, I would rather have a satisfied student. That is true, of course. I want my students to be happy. But if I have to make a trade-off between happy students versus effective learning, I will always choose effective learning, and sometimes that is hard. Sometimes it's not until 5 years, 10 years down the road do we look back and say, I am really glad for that difficult experience I went through as a medical student because it taught me something important, and I didn't like it at the time, but now I understand why it was important. So that's why crisis scenarios in a simulation center are so valuable. They put students in a difficult situation where they may even fail. But by failing, they learn, and it sticks. We don't want to intentionally make them fail. That's not effective. But to have a realistic scenario in which some students fail, that can be a very powerful learning activity, even if it, in the moment, is unsatisfying. So again, all things equal, yes, I want satisfied students. But I want students to learn more than I want them to be satisfied.
Yes, and with technology, there's always a risk that everybody wants to have that headset on. Everybody is excited, like, I want to do that game. And that's completely not important. And I see, for example, the simulation that I showed, the first pictures that I showed, the students sitting around, that afternoon, that makes so much impression. They really go home kind of upset, and they learn so much, and they start thinking about it for days. And that's impactful. I think that's more impactful than having a fancy headset and you can play your game.
Thank you very much, doctors. Vamos un poquito atrasados en el programa. Vamos a permitir hacer más preguntas acabando ahorita las sesiones. Y pues, on behalf of the ANFEM and the Mexican Society for Simulation and Health Sciences, I just want to say thank you very much for your time. Thank you very much for sharing your knowledge, your experience, and I think the most important thing, your passion for medical education and to improve what we are doing in our universities and in our simulation centers. So I just want to give you your diploma for your participation and to ask to the public for a clap for you. Un aplauso, por favor. Muchas gracias.